Thank you for joining us for part 3 of our free webinar series, Compliments of Downtown Women OBGYN, and this week with South Slope Pediatrics. We at Downtown Women are committed to your maternal well-being, not just how you're doing physically, but also how you're coping emotionally, especially during such a challenging time. My name is Gulzar Selbin Akshinet. I'm a licensed psychoanalyst and the director of the Prenatal and Postpartum Support Program at Downtown Women. With me today is Dr. Antoinette Whitehead, Senior Obstetrician at Downtown Women. She will be answering all your medical questions related to COVID-19 and the perinatal period. Dr. Whitehead is one of the most compassionate and generous doctors I've ever met. I've witnessed the way she works tirelessly for all you ladies, and it's a pleasure to have her here with us today. Hi, Dr. Whitehead.
Good morning.
How are you?
Oh my goodness, thank you, Gulzar.
It's true. Also with us today is Dr. Danis Kopenhaver, a general pediatrician from South Slope Pediatrics. She has been a general pediatrician in Brooklyn since 2014. She graduated from Cornell Medical School and Columbia for her residency. She's one powerful lady. She's here with us today while still on maternity leave. Believe it or not, she delivered only 8 weeks ago. We have some very impressive ladies with us here today. Hi, Dr. Kopenhaver.
Hey, good morning. Thanks for having me.
Absolutely, it's our pleasure. We're really happy to have you here. We also have Perry Thompson here with us today. She's my right hand, and we couldn't implement all these new additions to the practice without her. On behalf of the rest of the practice and the patients, thank you, Perry, for all your hard work.
Hi, everyone. Thank you for joining us.
Before we start, I want to introduce the Prenatal and Postpartum Support Program. We're here for you throughout the course of your pregnancy and your first year postpartum. Whether you're feeling overwhelmed or anxious, or you're not sure how you're feeling, we're here to support you in a variety of ways. During this pandemic, I'm offering virtual therapy sessions over Zoom, both individual sessions and various support groups. You can also contact me for referrals. You ladies are incredibly important to us. We at Downtown Women take pride in our comprehensive approach to helping you through your transition into motherhood, not only physically, but also mentally and emotionally. For those of you who haven't yet spoken to my associate Perry, you should reach out to her. She will call you sometime during your pregnancy or postpartum to check up on you. She's wonderful and super easy to talk to. She does a great job at supporting you all and is an amazing resource, so please use her. Last note before we begin, we created a feedback form to help us understand how to better serve you in this time. It will pop up after the webinar and will also be in a follow-up email that comes to you tomorrow. We'll have a poll during this webinar if I can figure it out. The very short poll is redundant to the feedback form, but answering all these questions will help us provide you with the best care possible during this time. There'll be another Q&A at the end of this webinar. We will do the very best we can to get all your questions answered. And some of the questions we did receive, I want to note, they were answered in previous webinars. So if we're not answering your question, you might want to look back at the previous webinar 2 weeks ago and watch that. The recordings of the previous webinars are available on our website under the webinars tab. Also, as I promised, in the last webinar that we did, our childbirth education class is now virtual. See, I don't let you ladies down. Our first virtual class is Friday, May 8th at 4 p.m. To sign up, please call the appointments line at Downtown Women. Perry's email is on the screen. If you have any comments, questions, or suggestions, please send them to me or Perry. All right, so let's begin. So first I'm gonna turn to you, Dr. Kopenhaver. Can you talk to us a little bit about what we need to know about COVID and how it's impacting our infants and children, and also give us some general information on infant care for our first-time moms?
Great. I'd love to. So I'm really happy to be able to come at this from the pediatric side. And of course, this is like a rapidly evolving, ever-changing situation with lots of people, doing research. That was Easter. So this is like what we have right now, and things are going to keep changing as we move forward. But so the first thing I wanted to talk about is COVID in pregnancy, like the late pregnancy, and then right in that perinatal period. So as of now, there is zero evidence, there's been zero cases of vertical transmission. So what I mean by vertical transmission is when a mom has the illness, is COVID positive in the 3rd trimester, she is not directly passed that illness to the baby before the baby's born, which is great news. There is some like very vague evidence that it's theoretically possible. So we can't 100% say that that will not happen. But so far in all cases of COVID positive pregnant mothers in the 3rd trimester, the babies have been fine. We don't have any real information about COVID infection in the early, like 1st or 2nd trimesters. That being said, there have been case reports out of China of babies testing positive for COVID within very early, as early as one case is in 36 hours. So there's evidence that the likely transmission is from close contact with COVID positive mothers or other COVID positive caregivers. Because of this, we have now, our country and a lot of our hospitals have implemented universal testing of all obstetric patients. I think that that's happening at NYU starting on Monday and has been in a few other hospitals in the city for a few weeks now. What that means, and with the data that we have right now, the AAP, the American Academy of Pediatrics, has come out with guidelines on what will happen, what's recommended to happen with you and your baby if you happen to test positive at the time of your delivery or at the time of admission for obstetric reasons. It's important to note that up to 14% of moms are completely asymptomatic and are testing positive at the time of delivery. So it's great that we're doing universal testing, but not having any symptoms still can mean we can be positive for the virus and shed the virus. So the current AAP recommendations are they're not going to be your favorite thing. So that AAP is currently recommending that if a mother is COVID positive at the time of delivery, that the baby is temporarily separated from the mother just to give the baby a bath, examine the baby, do vitals, and then to potentially separate the baby from the mother during her time of admission, which right now vaginal admission is about 24 hours and C-section admission is about 48 hours. You can room in with your baby, that it's not like a hard and fast rule that the baby has to go to a special nursery. If you do choose to have your baby in the room with you, the baby needs to be 6 feet away from you, likely in a covered isolette when you're not physically holding the baby. Breastfeeding is encouraged. Their breast milk of COVID positive mothers have been tested and there is no coronavirus in the breast milk. So it is recommended to breastfeed your baby. The AAP is being extra cautious and their first line recommendation is to give expressed breast milk. So to pump breast milk and then give it to the baby, ideally by a healthy caregiver, so a partner, a spouse, or another family member, to keep mom and baby separate. If you do choose to direct breastfeed, which a lot of women are, then mothers must wear masks and hand wash and wash their breast and nipple for 20 seconds with soap and water before any direct contact and breastfeeding. This is going to be their recommendation until the mother is considered well. So if you are symptomatic, that means 72 hours, which is 3 full days without fever, without any medication, or 7 days from the onset of symptoms, or 2 negative tests. So if you were completely asymptomatic and you test positive, it's like, how do we know when you're okay? They're recommending 2 tests 24 hours apart that's negative to then say you're no longer shedding virus. So most babies are not testing positive with these precautions. In fact, there was a study that just came out of Columbia where they already implemented universal testing, and all 18 babies that were delivered to COVID positive mothers, none of them contracted COVID-19, which is great. So no babies have had to go to the NICU for just COVID-19, but if for some reason your baby does need a little extra care and does need to go to the NICU, if you are COVID positive, you will not be able to go to the NICU at this time. And we can answer further questions of that later. I'll just hit on that right now. Luckily, for the vast majority of you guys, you're not going to be COVID positive. So I just want to go through now like normal newborn care in the hospital and things that are going to happen anyway, but that are going to be a little tweaked differently because of what's going on with COVID-19. So with normal newborn care in the nursery, typically With a vaginal delivery, the baby wouldn't be bathed maybe for up to 2 days. Now they're going to give a bath within the first 24 hours just to make sure there's no transmission of anything. Rooming in is going to be encouraged for you guys. Breastfeeding is definitely going to be encouraged, and all those support systems for that are still in place. Vitamin K, which is an injection to help with blood clotting disorders, is given in the delivery room, and that's mandatory. That's still mandatory. Erythromycin ointment, which is an antibiotic ointment on the eyes to help prevent bacterial infection, is still very, very strongly recommended. The hepatitis B vaccine is always offered in the first 24 hours of life. Typically in my prenatal visits, when I'm at South Slope Peds before moms come in, when parents ask if they should get the Hep B vaccine, I discuss the pros and cons and talk about how we still give it at the office. It's a 3-part series to be immune to hepatitis B, so it's fine if you give it at the newborn visit, outpatient 1 month, or the 2-month visit, depending on what vaccines your pediatrician has. However, in this time, I think it's the best practice to get all your vaccines as early as possible so that your baby is as protected as possible. So I would strongly encourage opting in for the hepatitis B vaccine at the hospital. Newborn hearing tests are still going to be done in the hospital before discharge. And then the thing that might be a little bit different is the newborn screen. So that is a state mandated screen. It's a heel prick in the baby. It's 5 little drops of blood that checks for I'm forgetting, I think it's like 24 tests, severe illnesses that are very important to know if your baby had them in very early days. It has to be done 24 hours after the baby's born. So if you're discharged right on the edge of 24 hours, there might not be time to do that test. Or if the test is done and they send it to the state lab and it's not adequate to be tested, you may have to repeat that test at your pediatrician's office, or they may do it for the first time at your pediatrician's office. So that's something that might be a little bit different because of COVID-19. Okay, next slide. So the next thing is what to expect with your first doctor appointments. So a big thing is you should start thinking about, if you haven't already decided, where your new baby is going to go, because you're not able to leave the hospital without knowing your pediatrician. They're going to say who's going to be your pediatrician, who's going to be your first appointment. I'm at South Slope Pediatrics, which is on 5th Avenue in South Brooklyn. There's lots of great, we love babies, obviously. But anywhere that's close to you and fits within what you're looking for in a pediatrician, and locale, I think, matters right now. So you might want to touch base with them, find out what the protocol is for calling to get an appointment, and then what you need to do from your standpoint to make sure everyone's safe. So likely parents are wearing masks. We're not, at my office, we're not asking siblings to come in for that first newborn visit. For other visits, we're just really trying to limit the number of people that are in the office. And then you can ask any other situations. A lot of offices, I know our office is only doing well checkups right now. All of our sick visits are virtual, so like no one with any symptoms are coming in. Other offices are splitting things up, well kids in the morning, 6 in the afternoon, and disinfecting. So you can call your office and find out what they're doing there. So your first visit typically is 1 to 5 days after your discharge, but with babies being discharged so early, it's usually going to be within 1 to 2 days of you being discharged. The most important thing is to track how many pees and poops your baby's having in those time that you're home. They'll give you little sheets at the hospital to click in, or apps. Hooray for like smartphones. They're like your second or third brain. I don't remember anything. They have apps that sync. So if like your partner changes a diaper and you didn't know about it, it saves my life. And then the biggest thing is babies all also lose a little bit of weight in those first few days. So they're going to really track your baby's weight gain. And then they might check for jaundice, which is yellow tint to the baby's skin. If you're COVID positive, if the mother's COVID positive, sometimes these newborn visits are done via telemedicine. I know that we've done that a couple times at my office as well. The next visit is usually within sometimes it's the first 3 days, depending on weight gain or weight loss, but up to the first 1 to 2 weeks. These weight checks might be done remotely and via telemedicine just to help cocoon and protect babies and families from exposure. The 1 month checkup is weight gain development, and that one may also be done remotely depending on what your office is doing right now. The 2, 4, and 6 month checkups should be done on time and in person at your doctor's office, because there are vaccines at this visit, and those are very important. There is some concern right now that because of the stay-at-home orders that parents are delaying routine checkups and then delaying vaccines, and we are going to potentially get below herd immunity on diseases that are devastating, like measles and whooping cough. So it's very important to show up.
So just to be clear, you do not believe that people should be delaying the vaccines?
Do not want anyone to delay vaccines. A lot of offices are coming up with interesting solutions. So like, especially for older kids, not the babies, they're doing like drive-by vaccines. They're like car windows. So, you know, reach out to your doctors and find out what they can do so your kid can stay on track with their vaccines. All right, so next slide. So this is kind of, I mentioned cocooning, which includes like caregivers, family, and visitors. And this is obviously what a lot of people are interested in thinking about. So at this time, most pediatricians are not recommending people coming to the home that you don't have any control over, have any good sense of like what's happening outside the home. So like doulas, lactation consultants, night or baby nurses. This will change likely as the pandemic evolves and we kind of open up a little bit more. I know it's really hard, like Golzar mentioned, I have a 8-week-old and the nights are hard and rough, and it is important to have some support systems. So if you've, you know, met with a baby nurse and you can have a really frank discussion about what their situation is and how they are staying at home, you would want someone to be really staying at home for at least 14 days before they come into your home, and really have a frank discussion about that and think about how they're commuting back and forth. Because really that's an important source of potential infection. For your support systems like family, caregivers over 60 years old are not advised if mom or another family member is COVID positive. They're at high risk of having complications and being hospitalized. So we're really not encouraging that. However, if everyone's healthy, you can think about having other family members come in to be your support system. I consider that essential travel. My baby was born kind of right before all the lockdowns and stay in shelter in place advisories were happened. And we talked really long and hard about family coming. We decided it was essential travel. I would consider newborn care for a long period of time essential travel, but you need to think about that 14-day quarantine. So if you want family to come in to stay with you for a period of time, if you can have them come in 14 days before or after the baby's born, they need to travel, stay at a hotel for 14 days or stay in someplace separate and then come in and help you. If it's just for a short visit, I wouldn't consider that essential. We need to wait till things are a little bit more calm. And then that's with other friends, family. No one needs to come visit the baby yet. Thank goodness for Zoom. We'll talk about that when the baby's a little bit older. We can do the next slide. So all of this I call cocooning. This slide is really what I recommend kind of for any family, even without COVID. So you're going to stay inside as much as possible. Nothing's really open right now, which stinks, but also like you were going to cocoon anyway and kind of hunker down in your home and really like bond with that baby and kind of call the first 6 weeks of newborn life survival. You're just survival mode. Like you don't have to have any higher plans. So you're staying inside. If you feel like going for a walk, really stroller in the early days, carrier if you can cover when there's no one else around, wearing masks, lots of hand sanitizer and hand washing when you come inside. This is also my recommendation. The next one, no one's allowed to kiss that newborn's face except mom or dad or your partner. So this is because not just COVID, but other infections are really easily transmitted, specifically herpes virus, which can be from cold sores. And in the newborn phase, their immune systems are very weak and you can get lots of different illnesses. So as an example, and I know it's really hard to tell family they can't kiss their face. When my son came home, I strong-armed my mom when she went in for a kiss on the face. Was how much I believe in this. So, you know, just let people know expectations early if they are coming over to help take care of your baby. I think it's fine. You sterilize all your nipples and bottles and everything initially, but after that, soap and water is fine. But if mom becomes positive or is positive initially, then and breastfeeding, you're gonna wanna like sterilize bottles and nipples and pump parts every night, in addition to washing with soap and water. Older siblings, I call older kids lovely little germ bags with no sense of personal space. They're great, but they're disgusting. Luckily, because they're not out and about a lot right now, they're not bringing home all the germs that they typically do, but it's good to start talking to them early about like the older sibling, like special places, the baby's feet or their belly, and they always love to get kissed on their feet and their belly. But if you want to touch their face or kiss face, you got to talk to like a parent first. And that's always my recommendation. And it's especially important now, especially if things do start opening up and kids are going to be out more. And then always hand hygiene and washing hands and hand sanitizer. We can do the next slide. Oh, so this is kind of my like practical slide, things to have at home so you don't have to like pop out to like Walgreens or stand in line and do that thing. If you have a kid at home, or if your baby's coming up soon, if you can't get this stuff, don't stress and don't spend $1 million from some price gouger thing on Amazon. You'll be fine. But like, this is a good just general list to have. So ointment-based diaper cream, A&D Aquaphor, a zinc-based diaper cream like Desitin, butt paste, triple paste, infant nasal saline. The brand is Little Remedies for little congested noses, a rectal thermometer. I know that they sell a lot of the like temporal thermometers, and we're probably going to see those a lot more as there's more like scanning of temperatures to get into places. The ones you can buy over the counter, I find are very all over the place. And even my parents that had this before would get just like drastically ridiculous numbers. And for an infant under 2 months, rectal is the gold standard. Have a rectal temperature thermometer. Rubbing alcohol or alcohol pads, don't stress if you can't get this. It will be fine, but it is nice to have at home. Cotton swabs like Q-tips. The bottom ones, the next one's on, you can have in the house, but I wouldn't want you to use them without consulting a doctor or a nurse first with your pediatrician. So antibacterial ointment like Neosporin or Bacitracin, 1% hydrocortisone cream, like cortisone, clotrimazole cream, which is Lotrimin, like athlete's foot cream. This is really good to use for yeast rashes. You would want someone to diagnose it via telemedicine first before using it, but then you don't have to worry about going to the pharmacy, and yeast rashes are super common. Infant vitamin D drops, if they're over the counter, they're recommended for all newborns to make sure the bones are strong. And then optional gripe water and infant probiotic drops, which can sometimes help with fussiness. So if you want to get that just in case your baby might need them, also fine to have on hand, but talk to your pediatrician first about using them.
So just to be clear, no one should use them without their pediatrician's approval?
I mean, nothing's going to really hurt your baby. Those things that are on my list, but the hydrocortisone cream, the antifungal cream, the antibiotic cream, and the gripe water, I would say talk to your pediatrician first, whether it's an actual visit or like messaging back and forth, just so we're making sure we're not missing something else that might be that might need something else. But they're super common, and a lot of my patients use them really early on. So it's just nice to have them in the house in case you need them. So really common newborn concerns. I hope I'm not going too fast or too slow. So also really very common, but you're going to be we're all anxious about our newborn babies, and we're going to be more anxious with what's going on. So breathing, which is obviously on everyone's mind with COVID. Newborns breathe really weirdly. It's called periodic breathing. They pant. So a lot of time they breathe much faster than we do, and even older children do. And they will do this thing where all of a sudden they'll go, way too long of a pause, and then they'll breathe. Completely normal. So if your baby's doing that, anytime you're concerned, call your pediatrician, but that is a very normal way for a newborn to breathe. Newborns also sneeze a lot, totally fine. Cough, and you'll see some asterisks because I'll talk about that in a second. Coughing occasionally is normal, especially when nursing, or if they're taking a bottle, they'll clear their throats a little bit. So an occasional dry cough, totally fine. Babies also unfortunately cry a lot. Irritability and crying is pretty normal. Poops are very strange in the early days, and it's really common for first-time parents to worry that their baby has diarrhea because they are really seedy, really runny. They suck into the diaper, and they can be incredibly frequent when that baby is very well fed after the first few days, sometimes up to like 20 times a day. That's okay. That's great. And then rashes, and I mentioned these mostly because sometimes you're always just going to be on high alert as your baby's sick. So rashes are really common, especially week 3 through 8. So maybe your baby might have like pristine newborn skin, and then all of a sudden they look like an acne-filled monster. My daughter looked like that too. So pustules, they can get really scaly. It usually starts around week 3 and can really get worse. And then typically it's getting better by around week 8. But again, always call your pediatrician if you're very concerned. We can do the next slide. So when to seek medical care. For sure. So fever, that's always the biggest thing for any newborn baby or really infant under 2 months old. A rectal temperature of 100.4, even if you just get it one time, is an automatic evaluation for your baby in the emergency room. So I know it might feel like, oh, I shouldn't take my baby because of exposure. Actually, right now, children's hospitals are pretty calm and chill. It's not so busy right now. So from that perspective, don't stress about taking your baby. Also, they always take newborns back very quickly, and then they need to be evaluated for a serious infection. That was always going to be checking for a urinary tract infection or a blood infection or a spinal infection, but now it's also probably they're going to check for COVID-19. Dehydration, so that's why you're counting P's. They're going to talk to you, but you should have 2, 3, 4 P's a day. It's okay in the early days if there's no poops, as long as the baby's peeing. True lethargy, so babies are really sleepy, but if they can't suck, when they're asleep, if their arms should be curled up, if you tug on them, they'll kind of snuggle back down. If that's not happening, if they're little wet noodles, we need to be seen by a doctor. And then coughing fits, repeated coughing, constant coughing, multiple times in an hour. We need to call a pediatrician to decide if that baby needs to be seen. And then respiratory distress, which is we call pulling. So that's when a baby is constantly breathing in and fast using their muscles. So you might be able to see if I'm pulling at my neck or my nostrils are flaring, or if there's a lot of movement with breathing, kind of like you think about deep yoga breathing. If that is happening consistently for more than 30 minutes, then we need to call a pediatrician to decide how and where that baby should be evaluated. And then for my last slide. So symptoms of kind of the big thing, COVID-19 in infants and children. So currently it's 2% of all positive cases are in the United States or in children under the age of 18, 1.7% in New York City. The reason infants under 1 are more likely to be admitted than older children. And what children are typically presenting with are sort of similar to adults, but a little bit different. In the younger babies, it's typically fever. So the most recent kind of case report I could find in very young infants, where there were 5 infants under 3 months that were COVID positive, and they presented with fever, often just for a few hours. They were admitted. They were only admitted for 1 to 3 days. They didn't need any intubation, and they were very, very well appearing on discharge. So that's really reassuring. Kids are also having, as you can see, cough, nasal congestion, runny nose, sore throat, which isn't as common in adults. Some kids are presenting with just GI symptoms like diarrhea and nausea. And the older kids, fatigue, headache, myalgias, which are body aches, poor feeding and poor appetite. And then there's some reports that up to 13% in some studies are completely asymptomatic. Like adults, the incubation time from exposure to symptom onset can be 1 to 14 days, average is 3 to 10. And I think that's the end of my spiel.
All right. Perry, can you actually go back to this slide about the products suggested and just leave that on the screen for a minute? While we start out here. Okay, so I have a list of questions now for Dr. Copenhaver. Thank you, Perry. So we'll start first with COVID and pediatrics. So the first question is, I've heard infants might not be able to spread the disease at all. This would certainly inform how we interact with grandparents and think about childcare. I know you talked about this in your spiel a bit, but if there's anything else you can touch on a little more specifically.
Yeah. So there is some really interesting case reports. So a lot of that information is coming from case tracking out of China and out of Iceland and Norway right now. So in China, they did some tracking, and it seems like kids under 10 are getting the illness mostly from household contacts, not from outside like childcare settings or community. It seems to be always from family members inside the home. And then they aren't able to track out those children then infecting other people. So Iceland is doing a really big study where they're trying they're testing just everyone, like trying to test everyone at once. And I think as of now, the most recent data I saw is none of the children under 10 are positive. And then this one anecdote that everyone's kind of excited about, but it's one kid, is there was a British kid in the French Alps that was positive for COVID and flu and another respiratory illness. And before everyone knew it, he went to 3 different schools and was in contact with over 100 people, and no one got COVID-19. So it's an N of 1, meaning 1 kid, but everyone's kind of excited about this. So that may be why Denmark has allowed their younger kids, the kids K5 and K through 5, which is 10 and under, to go back to school, because they're hoping, kind of hanging their hat, that kids can't transmit it. but we just really don't have enough information to really say like 100% kids can't transmit it.
So it's just preliminary right now.
It's very preliminary right now. It's exciting and encouraging, but very preliminary.
And then also, do you have anything you could specifically recommend for care for an older sibling, like a toddler?
In terms of like keeping them safe from COVID-19?
Well, I mean, I think both in terms of if you have a toddler and you're about to go into labor, and Dr. Whitehead, you might want to speak to this a little too, and in general, just caring, like if you're caring for an infant all day and you need help with an older toddler.
Yeah, it's,
you know.
My son's a little bit older. He's almost 4. But it was always going to be a rough transition. I kind of think that like that transition, you might call it trauma, of having another sibling enter into the home was always going to be a little crazy. I'm sort of hoping that that's what he remembers, is that like, oh, my sister was born and all this crazy stuff happened. It's a lot of, you got to take care of the baby because that's the only time that's going to happen, but trying to have dedicated, if you can give your toddler 20 minutes of like, whether it's a partner or someone else, and you're like, this 20 minutes, I'm on the floor, I'm with my toddler, knowing that they get that dedicated time can really help kind of long-term, like throughout the day, the attention that they need. And then it's a lot of talking. You're just constantly talking to that toddler.
Dr. Whitehead, do you have anything you'd want to add to this?
I think you may mention goals are right about if women are going into labor, like what to do about like their older child. I think trying to keep consistency. I mean, a lot of people have their plans in terms of who's coming in if women start to contract or their water breaks, to kind of help their toddler through this time. And then I think it's a little bit different because like for introduction of siblings, people normally do these kind of meet and greets in the hospital and they can come, and that's kind of been taken away from us because of the visitor policy. But I think it could still be something nicely done at home, you know, where the baby, you know, is giving the gift to the older kid or vice versa. So I feel like a lot of families express that that's helpful too.
I've also heard, sometimes I think coming home, if mom is not holding the new infant, like it gets to come home and immediately embrace the toddler, and then, you know, then the baby comes in too, sometimes that can be really reassuring for the toddler as well.
Yeah, I mean, I think inevitably the toddler will be jealous of the baby because there is a loss in having to share. But I do think it's also really important for everybody listening to keep in mind that the medical advice in terms of COVID and help is always going to err on the side of caution, but that you have to do whatever's right for your family. If it's going to be too anxiety producing for you and your partner to take care of a toddler and a baby alone, or for you to not have a night nurse or a baby nurse and you need more help, and that's the thing that's right for your family, and your baby nurse is willing to take those precautions, you do what's right for your family. We want to also minimize the anxiety and the other hardship that comes along with the postpartum period, whether or not there's COVID. Okay, so the next question is, what are your safety recommendations once we bring our baby home? Any guidelines for things like delivery food, doing laundry outside of the apartment?
I think the same precautions that you were doing hopefully before. So when food's delivered, that you're maybe, if you can, opening outside the door, bringing in the takeout packages, immediately transferring it to your own dishware, throwing the takeout packages away, washing your hands really well before eating. Same thing with packages, depending on what your situation is. If you can leave them outside for 24 hours where they're safe and not going to get stolen, that's great. That's not true for most of us. So opening them outside, bringing the inner package in, washing your hands, and laundry. From everything that I've read about how the virus is transmitted, it's really, really hard for the virus to live on clothing. So there's a lot of laundry when you have babies. So if you don't have access to laundry in your home, send it out. When it comes back in, if you want to be extremely cautious, just leaving it in the bag that it's tied up in for 24 hours, then you can open it up afterwards and be very confident that there's not any like transmissible viral particles on the clothing.
I found that answer very helpful because I've been terrified to send my laundry out to wash and fold. Okay, the next question is, how might isolation affect infants? My baby isn't interacting with other babies, and we're considering not sending her to daycare if and when it opens. Do babies benefit from socialization, or is that more for toddlers?
I think it's important just to think about socialization doesn't necessarily need to mean a lot of people. That's your family unit. So in these very early days, it's just most important that that baby's bonding with you. So cooing at the baby, talking to the baby, reading to the baby. And in the really early days, it doesn't have to be baby books. It can be whatever you're reading. Maybe not the stressy stuff. But you know, a lot of that reciprocal interaction is what's very important for kiddos in the early days. And then even when they start to become really social, waving, clapping, you know, by then, depending on how old your baby is, maybe we're outside a little bit more. But a mirror is just really important because they don't know that baby's them. That's another baby they're interacting with, and is really helpful and fun to do for just developmentally anyway. And babies don't need like friends or buddies. They're with each other. Even toddlers right now are really doing well at home. They really just need that to feel really safe and secure in their home. So it's fine. It stinks they're not seeing their friends. And you can do like FaceTime and stuff with grandparents and that kind of thing. But there's enough stuff to worry about right now. The kiddos are really resilient. They're going to be okay. This is a trauma. We're going to figure it out as with every kid, but give yourself a break about socializing your infant. We don't need to do that. And also don't necessarily turn to screens. Like your kiddo, your baby, especially under 2, under 1, they don't need to watch Sesame Street to learn how to be social kind of thing. They're going to learn that along the way. But by all means, if you need a screen to get work done, do what you got to.
Yeah, I think it's really important to remember that watching babies interact with one another is fun for the parent, but it's not doing much more than watching the baby for the baby than it is when the baby's interacting with the chew toy.
Make friends, like you can make mom friends virtually. That's great. That's really important. And that's really what getting babies together about, is getting the moms together.
It's getting the moms to have relationships with each other. Yeah, absolutely. And I always recommend to patients who are early postpartum to read what they want to read. Just read it in a voice that will excite the baby. I'm more proud of that. I don't care if it's academics. I don't care if it's trash books, whatever you want. But right now, it's hard enough postpartum. Read something that's entertaining you and just read it like it's a story to a kid. They don't speak English yet.
Yeah, totally agree. That's great.
The next question is, we have a 3-year-old son who has asthma. I know COVID-19 doesn't seem to affect children, but I also know that this is a deadly virus that attacks the lungs. Does this put him at a higher risk for the virus?
So it doesn't put him at a higher risk of contracting the virus. Like he's not any higher risk than another 3-year-old if they both got exposed. But it does put him at a slightly higher risk of, if he caught the virus, of it being maybe a little bit more serious. So just like another cold that he gets, he's more likely to wheeze because he has asthma. If he does get COVID-19, there's a slight increased risk. I can't give you any stats because we don't have them yet, of him needing a little bit more support than another kiddo. So in the United States, the children that are hospitalized, a few of them, the underlying comorbidities, meaning illnesses, chronic illnesses that they have at baseline, are respiratory, the ones that are admitted, like asthma or more serious respiratory illnesses. So it's important to note that pediatrics wise, as of April 2nd, there are only 3 pediatric deaths in the United States, and none in China, none in Italy, none in Spain. So while it's really scary, by far and away, children are doing really, really well. And we're going to figure out eventually why that is.
When do you think is the soonest it might be safe for children of non-essential workers to re-enter group childcare settings, especially children who are too young to socially distance?
Ooh, I wish I knew. That's going to be interesting. I think a lot of the daycares, at least in New York City, are going to follow the DOE, the Department of Education, about school reopening. So I think the summer might be a little up in the air, and it might be dependent on caregivers and how the phased opening that the state is going to follow would be my guess, but I don't know when that will happen. A lot of other states still have had daycares open. So, our New York, New Jersey, Connecticut might follow like follow those daycares and see how they're doing it, and then use that as a model about when to open and how to handle it. It's going to be interesting. I mean, I think obviously a lot of parents are figuring out life without what our typical childcare is. So hopefully we come out on the other side of this with more interesting and innovative support and caregiving ways, but I'm not sure.
And also, there are plenty of different options. And I think if you have the means to do something that minimizes risk, it's really, and if you can afford it, there's no reason not to. Do you think that maybe like having a nanny or having an alternative or a smaller daycare? I imagine a lot of small settings, daycares or like co-op kind of situations are going to pop up in response to this.
Yeah, that could be really interesting, like smaller in-home or like group, like nanny shares have always kind of been a thing in New York, but maybe it's going to be more families that you kind of all make a plan together. I think depending on how your caregiver is coming in and out of your home, it's just important to think about what your risk level is, like public transit, car rides, Uber rides, like those sorts of things. So, as thank goodness, we are waning in cases, or stable and hopefully waning soon in cases in New York City, they're going to start opening up. People are going to be coming out more. So yes, I think childcare is very important, and that needs to start happening very soon. So if you can come up with ways that it's more one-on-one, you can come up with a plan with either a group of families or your nanny just for your single family, that is going to be really important to start happening soon.
So there are a number of things to consider. Would a nanny or a caregiver have to be taking public transportation, or would they be able to walk? If there is a daycare, are they doing like curbside pickup and drop off rather than parents going in?
Or checking temperatures before kids are coming in, which they are anyway.
Drop-offs and pickups.
Yeah.
So there's a lot to consider, but I always say to patients around this time that, you do what you can afford, and that's what you have that luxury for. And if you can afford to do something that's more cautious, great. And these are the times we have savings for. Yeah. The perinatal period is a time that we need to dip into our savings, not be saving more money. There's plenty of time to save for college. And a pandemic is also such a time. So it's important to keep that in mind when you're making these decisions.
Yeah.
If daycares are to reopen in the near future, what are the safety precautions that parents should take when choosing to send their kids?
So I think actually the AAP does have some, I looked it up last night, guidelines on this sort of thing. But I think the biggest thing is calling ahead. And I think a lot of daycares when they reopen are going to be very cautious about the children and their staff. So I would imagine that a lot of daycares are going to come up with a plan and reach out to parents, but I think it's going to be drop off. How are we going to stagger that? Or are we going to keep a lot of people, adults and children from coming in at the same time? Temperature checks, hand washing, going outside play. Where's that going to be now? Field trips, probably not for the first little bit, that kind of stuff. So just really, I think a lot of this with caregivers, it's going to be frank discussions. We're not going to have 100% but you're going to weigh with risks and benefits, and what feels right for your family and what you're willing to do. And then hopefully as more and more testing, we're going to be able to test more for actual illness. And that as we move forward, that will get better and easier and more transparent about who's sick and who's not sick.
On that note, do you happen to know offhand if the antibody tests are being given to children at all?
I don't think they're recommended right now. So what the guidelines are right now are mostly for adults. And it's if you've been exposed, I guess if you're exposed, a doctor might order them for you. We haven't at my office, as far as I know, written an order for any children to get antibody testing. So that'll be interesting. I think all the antibody testing coming out right now it's still a work in progress with what it means. Mm-hmm. Can we 100% say that you're immune to the virus? We can't say that right now. So.
Dr. White.
We've been starting to offer it, and I think we've had a few patients this week request it as well. But I agree with Dr. Coperhaver. I don't know what the utility of it is quite yet, and how do we use that to counsel our patients? So I think it's still a work in progress as well.
Yeah.
Great. And the last question about COVID and pediatrics is for parents with new babies who are not being exposed to anything in the outside world, germs, etc. Is there a risk that they will develop more allergies as they get older?
That's an interesting question. That's actually funny. My husband, whenever my daughter came home, he was like, I'm sorry, you're going to have all the allergies because you're not going to be exposed to anything. This comes from the basis of the idea of germ theory behind the development of allergies, so that our bodies need to be exposed to lots of different things so that we know what's the right thing to fight off and what's the wrong thing to fight off. It's also very genetic and some things that are going to happen anyway. So I think that's going to be long-term. We're going to have to see if kids born during this time are more likely to have allergies, but also like our kids are going to be back to eating dirt soon. I don't know how clean your apartment is, but once our babies are crawling around, like there's no way they're not going to lick everything. So germs still exist. We're washing our hands a lot, which is great. But I promise our kids are going to get sick again with just the basic normal stuff.
Okay, so now moving into general pediatrics. Should I buy a stroller or a car seat for my infant? I am concerned since most of us live in Manhattan and have no car. Now we will come back to car seats a little in having to do with delivery, but this is a really important question and I want to cover it twice. So go ahead.
Definitely get a car seat. Like even if you're walkable from the hospital and you plan on only walking, you need a car seat. If your baby needed to go to the hospital, if you needed to move in any sort of transportation, that kiddo has to be in a approved infant car seat, backward facing in the back seat. So you definitely need a car seat. I think a stroller is up to you, and depending on how you feel comfortable moving around the city, even though it's like minimal right now. So I can see if you don't want to invest in a stroller right now, but definitely buy a car seat.
And plenty of strollers have detachable car seats.
Yeah, you can like buy a base. They actually make really, really cheap bases for car seats. You can just like click the car seat into and then push the whole thing as a stroller.
And I think it's just really important to note that since we don't know what emergencies will ever arise in life, as we can all see, none of us expected this pandemic to come. It's great to have a car seat in case you ever do need to get in a car in an emergency. Do you want to add anything, Dr. Whitehead?
No.
When is it recommended to contact a pediatrician's office about enrolling your baby? How far in advance of your due date?
I think, if you're due tomorrow and you're like, oh no, you're fine. There's my office. So at South Slope Pediatrics, we have a meet and greet process. So if you'd like to join our office, it used to be an in-person meet and greet process. It's totally free. Now it's done virtually or over the phone, where we just talk through everything about the office and make sure it feels like a good fit for your family. A lot of other doctor's offices kind of do the same thing. I usually say 1 to 2 months out from your due date is a good idea. It just makes you feel confident, where you know where you're going. But again, I've met parents. I've met a mom literally the day before she had her baby, or sometimes babies that are still in the hospital. That's going to be a little different now that we're discharged so early. So we're happy to see your baby when you need us. But it is better to call maybe 1 to 2 months before you're due.
Although we are currently in Manhattan planning to deliver here, we are set to move back to Westchester by the beginning of July. Should we choose a pediatrician within NYU so that a mother and baby's records are the same place and early doctor's visits are in a familiar environment, or should we change our search and start looking at pediatricians in Westchester?
I think you're gonna have 2 searches. So I think where your baby is going to need a pediatrician in Manhattan during that newborn phase. And I think go where you're comfortable. If that's NYU, great, but you don't need to worry about like records being easy. Like that shouldn't be your priority. It should be like, where do you want your baby to go in those early days? Sometimes location is really important. How close it is, how can you get there, especially right now when we're trying to minimize exposure. And you're gonna ask a lot of questions to that early pediatrician. So find somebody that you feel really comfortable with. And then you also are gonna need one in Westchester. So maybe start like looking around and calling to pediatricians in Westchester as well.
My husband has sickle cell and I'm a carrier of the sickle cell trait, which means that there's a chance that our baby will have sickle cell. We're struggling with figuring out whether we should choose a pediatrician who specializes in blood disorders or choose a pediatrician first and a hematologist later on if necessary. Which do you recommend?
So in this case, I would definitely recommend a general pediatrician because you're going to want a general pediatrician for your baby's entire life. And then that newborn screen that I mentioned earlier actually tests for sickle cell disease and will let you know within your child's first month if they are a carrier or if they have sickle cell disease. And then based on that testing, you can decide if you need a hematologist. Sickle cell is something that all general pediatricians are comfortable taking care of from just like a basic level. Patients with sickle cell disease will also need a hematologist, and we work in concert with them. So right now, just focus on your baby coming and finding a general pediatrician that you feel comfortable with and that you really want to like grow with and build a relationship with. And then we'll figure out later if you need a hematologist as well.
Great. What are the benefits of cord blood banking for the potential use in young children?
This is interesting. We get this question a lot during our meet and greets and prenatal visits. So currently, we do not have the technology for one banked cord blood to equal anything very real therapeutically for a child. So you can't get enough stem cells from one cord blood for like a bone marrow transplant or those sorts of things. That doesn't mean that in the future we might not have like a really amazing technology that can use those stem cells for something very real for that one baby, like that one cord to one baby. So I kind of think of it as a very expensive insurance policy that you're not sure will ever pay off. So if kind of speaking to anxiety, if you have the money and it really feels important to you and it really gives you a sense of preparedness to have that cord blood banked, great. If it feels like a shoestring, or if you're like, I don't know, I can use that money for something else, like a college fund or a support system or childcare, because we don't really know what that, if that cord blood is ever going to be helpful, and you have to pay annually to keep it frozen for the duration of your child's life. So
yeah,
a lot of money.
And I feel like I counsel patients the same. I counsel patients the same way. So, unless I feel like there is like a strong family history of blood-related cancers, or I know some of the other research is for, preterm infants that are born very early. That's another kind of emerging area. I would agree. I would feel like if I had to quote a percentage of families that do it, it's probably about like 10%. And of that 10%, the majority of them are doing it as a what if or a just in case.
Yeah.
Great. So I just launched the poll. So the poll is running. If everyone could just fill it out real quick. There will also, again, be a feedback form at the end. And I know I'm really obnoxious with all this data, but it's really helping me get you guys what you need. So it's important that you fill it out. Okay, so now we are going to move to Dr. Whitehead, and we're going to talk about, first I'm going to ask one general COVID question that I'd actually love to hear you both answer, and then we'll move to COVID and pregnancy. So the first general COVID related question is, there are a lot of hygiene practices going on from person to person. I'd love to understand what the best practice is. Some people are in masks and gloves, some are not. Some people are changing clothes and washing masks after they're stepping outside. Some people are taking showers. It's a lot of information, and I'd love to get some clarity and guidance on what the best practice is.
Mm-hmm. I think it's really important especially now the last few weeks, we have announced or decided, like when you go into the general public, that you are wearing a mask, that you are still practicing social distancing with being at least 6 feet apart from people. Let's say if you go for a quick run to like a grocery store or to pick something up. The gloves, I don't necessarily think are required. I think some people feel more comfortable with using that. I think the biggest thing for me is masked when you're out, good hand washing technique, using hand sanitizer. I think where it comes into, or where I would think more important to start washing clothes or be really diligent in that. I think if you're an essential worker and you're going to work every day and there's potential exposure, then being diligent about coming home and putting things in the wash. But I think if you're stepping out for a quick walk or a quick errand, I don't think so. But again, in this time, it's a pandemic, it's an unusual time. I think that if this helps you feel like you have another layer of insurance to keep yourself safe, obviously you can implement those things, but I think the biggest is masking, hand washing, and hand sanitizer.
Yeah, I agree with that. I even during, non-pandemic times, I do, once there is group childcare, I often have older siblings. If they came in when they're around lots of kids, I would say part of your like coming home routine needs to be that kiddo takes off their shirt or like their outer clothing that they were around all the other, like I said, lovely little germ bags, and then they like wash their hands and face. But I would say that's with a bunch of people together, which we're obviously not doing right now. So I don't think that's necessary either. And just lots of hand washing. Asking about the mask washing, if you're wearing like a cloth mask, I think that comes from, if your mask is visibly like damp, like if you've gone for a run and worn it, or if you've been in a public space and it feels damp, then washing it and drying it might be important. But if you've just like taken a walk around the block, it's fine to get the masks are protecting other people from what you might have. But I think what I've read and what we're kind of doing is if the masks feel damp or if we've worn them multiple days in a row, then we're washing or just throwing them in a hot dryer.
Great. So moving into COVID and pregnancy, what is your advice for couples who would otherwise be trying to conceive if not for COVID-19? And if the advice is to wait for how long?
Got it. I think for me, it depends on the patient's situation. I think for my patients that are younger, that may not have health conditions, I may encourage them to wait a little bit longer as the pandemic starts to slow down. I think for patients, as we know, as we get older, it really changes our ovarian reserve. And so if patients are 35 and older, and they are more anxious about trying, I think there's different things that we have to think about. But I would encourage patients to think about if they're at this point trying to decide what to do. The great thing about our office is that we've been offering like telehealth visits and virtual visits, so we can at least have a conversation, go through personal history, family history, and then we can help direct you further. But I think it's multifactorial in terms of where we say maybe hold off or go forth. The hard part is that we don't have a lot of data about COVID-19 and in early portions of the pregnancy. But it seems thus far that women who have been infected early on, from what we're seeing around the world, still have healthy pregnancies and healthy deliveries and healthy babies. So from our small amount of information we have, it seems reasonable. But I also think we have to think about anxiety level when there's natural anxiety, just deciding to start a family in general, let alone doing it in the pandemic.
Yeah, I do think it's really important to think about how much anxiety is going to impact your pregnancy, being pregnant within a pandemic, and also how long you've been trying. Is there a long history of infertility? Is it going to really be a lot on you emotionally to wait? And do you think you can handle the anxiety of being pregnant during COVID? So it's really important to let that also be a part of your decision. And the next question is, could you talk a bit about how care looks in early pregnancy with fewer appointments? I'm worried that I will not receive all necessary tests and care with reduced appointments.
Yes, of course. I think this was looked at really closely and kind of working with our team at Downtown Women, also our high-risk specialty team, our maternal fetal medicine doctors at NYU, to see where can we still make sure that our patients have comprehensive care, but also social distancing with keeping them, with multiple trips to the office. I think what we've been really encouraging patients to do is trying to kind of combine things where, doing their nuchal translucency in the office, which the nuchal translucency, I don't know if anyone, where they're at in their pregnancy, but Down syndrome screening or chromosomal testing, trying to combine that with other office visits. And then from there, having our patients do their next big thing in the second trimester, I always explain, is about structure. So their detailed anatomy scan at NYU. And chasing that, or kind of to follow with that, instead of having patients come back into the office, having a telephone visit with one of the OB providers to review those results and kind of talk about what the rest of the pregnancy looks like. And And so we're still getting all of the essential tests. We're just doing it in a different way. I think that, we encourage this. We also have to see how things evolve as we come down from the peak of the pandemic and move forward. But I think it's still going to be key to social distance. And we've adjusted our office schedule to be able to do that, to be able to see patients, to be able to do telephone consultations from home. And I think patients, we can chat about what feels most comfortable for them, but I just want to be reassuring that we are not missing anything. And we've gone kind of through this very thoroughly with our Downtown Women team and with the high-risk team to say what are the most important tests that women have and making sure we're not missing those. And obviously, if there's ever any concern, so if women are in between these scheduled appointments and there's spotting or bleeding or something worrisome, we're not saying that you can't come into the office. We definitely still have visits available so that if something comes up, 24 hours, 7 days a week, we have our after hours line. So to say we're here, we still want you to have a very healthy pregnancy, but we're just trying to minimize exposure to, patients coming in, coming out, being in the environment, exposure to COVID-19.
So I have a article here from Emily Goligoski. Does anyone know how to say that? Sorry about that. I believe she's in the audience with us today, so we're happy you're here. Perry, can you actually put the article up and maybe share the link in the chat if you can? The World Health Organization and others have found success with models averaging 8 appointments. Most countries in the world have less frequent visits with better outcomes. The American College of OBGYN suggests that clinicians group vaccines and screenings together to reduce the overall number of in-person visits. They recommend 4 ultrasounds, first between 11 and 13 weeks, then at 20, 32, and 36. In addition to the virtual appointments where people can self-monitor. Can you say anything to that?
I think even pre-COVID that we as a group, we're always reevaluating, are we, giving our patients the utmost care? And it has been talked about before, where are visits and at what point in the pregnancy are they absolutely necessary? But I think it's interesting and I think reassuring for if we look at other models that they have lesser appointments than we do, but the outcomes for babies and moms still seem to be positive. So I think even before this, we were thinking about how to tweak or balance that. But I feel strongly that we've, done an awesome job of keeping things so that moms get their care and we're not missing anything.
Great. What are the consequences of having had COVID on a pregnant woman?
I think that in terms of a couple things, I'd like to just kind of talk about for our patients that have been COVID positive. The great thing that we're seeing clinically taking care of women every day is that although we know pregnancy makes us more susceptible to infections, that our patients that have had it, it's been very mild, like mild upper respiratory symptoms, fever, but we have not had very sick patients. Most patients have, recovered very well. And I think that there's also this component of, patients being asymptomatic, which we're trying to figure out that with starting universal screening, which we're going to start that at NYU actually this week. So that is hot off the press, or a new topic that we'll get into and talk about a little bit more today. But yeah, so we've been telling patients if there's any respiratory symptoms, fevers, we can help direct patients of where to go. But thus far, it seems, in our clinical practice that women have been doing really well if diagnosed with it.
What are the self-care best practices in pregnancy? How can I connect with other pregnant women digitally?
So starting today, we're here. This is perfect, which thank you, Golzar and Perry and Dr. Lajoie for launching this. And then Dan is coming in and joining us. I think that I've really been encouraging people to do the Calm app. I think meditation is huge. I think trying to maintain some form of exercise just to get endorphin release, which is great during pregnancy regardless, and also during a pandemic. And then I think, reaching out to like Goals is an excellent resource if patients have any questions or concerns, either to partner with her, or there's other resources in the community that we can help women if they feel like they're struggling.
Yeah, we are running a lot of support groups at Downtown Women, and so there are times where you can join them, both pregnancy and postpartum. So you can always reach out to us, to me or Perry, and we'll get you in one of those groups. There's also an app, it's like Tinder for new moms, called Peanut. Some people absolutely hate it, just like some people hate Tinder, but you can always use that to meet other moms. I imagine it's probably doing pretty well right now. And then Park Slope Parents or these different groups on Facebook for your neighborhood is also another great way to meet other pregnant or women who are going to deliver around the same time as you. So let's move on to COVID and delivery. What are the latest updates for labor and delivery at NYU?
So I would say the biggest update is that, remember, previously we were doing screenings on admission through a list of questions surrounding respiratory symptoms, temperature checking, and now we are moving to universal testing of patients. So not of partners. Partners will still have the same testing with temperature checks and a questionnaire. What this looks like is either if women are coming in labor, or if moms are scheduled for C-section delivery, moms that are scheduled for C-section delivery, when they go to do their pre-testing blood work, that COVID swab will be added in. If women are coming in labor, we're sending that assessment, which normally the testing comes back, pretty quickly. I just want to convey to all of you, our patients, that this doesn't automatically mean that your baby is taken away from you. There is a whole kind of algorithm that we have to go through and consider the entire source. And so looking to see, I think, if moms are, for example, we had a mom who was tested positive, came in labor, but her symptoms were several weeks ago. And because she wasn't actively sick with fever, respiratory, there's a multidisciplinary approach, but infection control, infectious disease, MFM, everyone kind of came together as a group and said, okay, in her situation, there's no reason, to isolate the baby. The baby could room in with her. So it's going to be on a case-by-case assessment. And I would think if we look at the data from other hospitals, like at Mount Sinai, the asymptomatic rate has been about 30 to 40% for patients coming in. But I think that's, again, because patients are asymptomatic, that doesn't automatically mean that there's these interventions to take the baby away. I think if moms are COVID positive and really truly ill, then yes, there's going to be a discussion about that. But I just want to reassure families that that is not always the case. We have to take into kind of the whole picture.
Great. And Dr. Copenhaver, do you want to say anything about discharging separately or the response in the NICU?
Right. So if the baby's well and mom is well enough to go home, even if mom is actively COVID positive, either asymptomatic or even symptomatic, they're going to be discharged at the same time, typically. They're not going to hold the baby just because mom's sick if the baby's well. They're going to discharge to a well caregiver. But if that's your partner and you live in the same home, you're all going to go home, which is good. If the baby needed any attention in the NICU, which is the neonatal intensive care unit, whether that's for symptoms or something related to COVID or for any other reason, babies need help in the NICU, sometimes transitioning after birth for other reasons. If mom is well enough to go home after 24 hours, if that baby needs to stay in the NICU for 1, 2, 3 days, that sometimes is a separation. My before the pandemic, my first son was early and premature and in the NICU. And so he stayed in the NICU for 10 days and I was home after, 48 hours. It was a little bit different with visitation. I think, it's case by case. If mom is healthy, COVID negative, should be able to visit the baby in the NICU and be there with the baby. I'm not sure what the status is if mom is COVID positive and the baby needs to be in the NICU. I think we asked,
do we know, Dr. Whitehead?
Oh, in terms of babies in moms, so typically what happens is that moms cannot come to the NICU, and then partners or spouses are cleared by the NICU if they want to come visit the baby, but moms are not able to come in.
if mom is COVID positive.
If mom's COVID positive.
Okay.
Yeah.
So Dr. Whitehead, could you tell us a little bit about your experience in the hospital in the time of COVID-19?
Absolutely. I've been expressing to a lot of people, and just if you're on this webinar and I've seen you in the office, I feel like it's the same labor and delivery with a little bit more of a get up. So we have our masks, we have our shields, but I don't feel as though it's taking away from the beauty of birth. I feel like this, and for a lot of other people, like nurses, other doctors, have really felt like continuing to do what we do and take care of moms and babies has been a glimmer of hope around this time. I don't feel as though the hospital, like when you step, I think a lot of people are very surprised coming into the labor and delivery floor. You don't sense that there's a pandemic. You really don't. I mean, the nurses are still joyful. We are, it's still a birth of a child, and that hasn't been forgotten. So, yeah.
Great. I do see that we have 10 questions in the Q&A. We're going to try our best to get to them, especially since there aren't that many. I think we'll be able to cover them. So if you just bear with us, ladies, we will get to your questions. I have another article here. Perry, can you put on the "Don't Be Afraid of Giving Birth in a New York Hospital"? So this article is by Spencer McClelland, who's a former NYU resident and is now an attending. And I'm just going to read a section of what he said. 1.9% of women have symptomatic coronavirus in labor, only a subset of whom have severe disease. And the most recent City Department of Health data shows that 2.4% of women will suffer life-threatening complications during labor unrelated to COVID-19. With this in mind, having a doctor you trust in a hospital that is equipped for the most common emergencies is key. If you move, will your care be the same as before? Does your hospital have the capacity for emergency C-sections? Is there a blood bank on site in case you need a transfusion? If your baby suffered a complication, is there a neonatal ICU, or would your baby be transferred? I know that that's some scary information, but it's a really important point because it's how we're going to keep you safe. Do you have anything you want to say to that, Dr. Whitehead?
Well, I think that he brings up a lot of valid points. I've had this conversation with quite a few patients over the last several weeks when women have been thinking about, do they want to stay and deliver in New York City? Should they go elsewhere? I think the silver lining of being the epicenter is that we have quite a bit of experience now in terms of what to do and how to take care of people. Being a larger academic institution, there's definitely more supplies readily available for us. And I think that, some people have fled or thought about going to smaller community hospitals, and just my thoughts to them, even as all of this was going, is that, would they be able to take care of you the way that we could take care of you at NYU? And again, I think the other thing is that it's a different team. It's some people that you don't know, that you haven't established a rapport with. So I think, we've been very encouraged by families to stay with us and stick with us. And obviously our jobs are for women to have very healthy pregnancies and deliveries. And at any point in time, we thought that wouldn't be the case here. We would not hesitate to convey that. But yes, I think there's a silver lining to be part of the epicenter for sure.
Yeah, it's really important you also trust your doctor, because this is a moment where labor is a moment where if you don't have confidence in your doctor, that can have much wider reaching implications in the future and feelings of trauma or of not being heard. He goes on to say, hardship breeds expertise. New York hospitals have become experts not only in treating COVID-19, but also how to handle the disease during pregnancy. He goes on to say that New York City hospitals have braved the most recent peak of this disease, weathering the acid tests of its ability to keep essential services for labor and delivery running essentially unchanged in midst of a storm, while smaller areas with fewer hospitals see greater stress on their hospital systems than New York City did. So I think I'd like for you to talk a little bit about the fact that has it changed? Do you feel like the care that people are getting in delivery is the same?
No, I think that the care is absolutely the same. I think what I've been trying to convey to patients is that being in a large academic institution, it reminds me, a patient asked me, well, if I need an epidural, is an anesthesiologist going to get pulled somewhere else and I won't have the opportunity for pain management and labor? And my thought, and even going through the peak of COVID and now things calming down, that has not changed it, because there are other parts that the hospital pulls from first. So all of the anesthesiologists that were doing scheduled cases, that those are not happening right now. They are the ones that are kind of floating in a sense that can go and help. So we still have our obstetric anesthesia team. We still have a full board of nurses on board. At one point, a patient asked me, well, would you get pulled to go help in the COVID units? Yes, if I volunteered. So meaning, yes, some doctors have volunteered to go be part of the COVID army, but it is not broken down our team in any ways. I feel like the Downtown Women team, our colleagues like Spring Street OBGYN, we've all have been there to be able to take care. The faculty practice have all been there to be able to take care of their patients. So I don't feel like this is like they're drafting us to come over. Perhaps some people have, volunteered to go help, but our team is still very strong and well-stocked in a sense across the board.
What is the protocol if labor and delivery units at NYU don't have enough space for pregnant patients? Is that even a concern?
I don't think it's a concern, and all goals are, because I feel as though when you're talking about maternal and fetal health and a neonate, you have to be very careful in terms, especially in the realm of infection. And so there has not been a movement towards taking over areas of labor and delivery for, COVID patients. I mean, they have been keeping their care in Kimmel Pavilion, which is separate. And so, which it's ironic, we were upset we didn't get a part of the new hospital, but now we're actually glad that we didn't, because it keeps us separate or apart from them. But I don't think that they could take our resources, and I also don't think they can move us to a different part of the hospital, because we need specific things like fetal monitoring and to be near the NICU and being near the ORs. There's so many things across our specialty and how we take care of patients. I don't think that they could touch our resources or move us.
Great. Can you quickly just say what protective equipment will patients be required to wear during labor in May? Do you know? Is it just a mask?
At this point, just a mask. Definitely when you're coming in through travel through the city, I think depending on how women feel, some women have kept it on during labor, some women have kept it on for their C-section delivery, and we are masked the entire time, so protecting you from us. But I think it depends on, obviously working through contractions or going through the surgical delivery. A lot of women at some point may pull it off and then replace it. It's a tough thing. It's a tough thing to wear, but mask at this point in time, yes.
Are partners allowed to stay throughout the entire admission? Now, they are, as long as they don't leave, right? Once they leave, they will not be allowed back on the floor.
Correct. So the thought is that everyone comes in together, there's the delivery, and go home together. So bringing everything you would need, like car seat, toiletries, clothing, everything for after, They're trying to avoid the in and out of the hospital. I mean, normally people will, come in, they might go home and run and pick something up and come back. We're really trying to minimize that. And so I think in the setting of families that, let's say they're having their second or their third baby and the partner is there for the birth and then needs to go home and help with the childcare, that partner can come back, but then would only be waiting for pickup in the lobby for the patient.
What are the implications for Cuomo adopting the recommendations from the COVID-19 Maternity Task Force at NYU and Downtown Women? Particularly interested if this means we can have our partner and doula present, assuming there's enough PPE. Do we know the answer to that yet? Has anything changed?
Not as of now, goals are. I know that task force basically rolled out this week, and them, saying that we feel like doulas are essential workers. I think it's going to be at like a hospital, case by case basis if they decide to allow them to come back in. I mean, we love our doulas, we miss our doulas, but obviously it's going to be a discussion with hospital administration before we can say that that's happening.
I promised someone we would get to this question, and here we are. Is private cord blood banking an option at NYU Langone? Do they let third party come in to collect the blood given the COVID scenario? We got an answer on that last night, right?
Yes, we did. So they are still processing units. The person that I talked to is from StimSite. They, at this time, based off a small study that came out of Wuhan, they feel as though that there's not any transmission even for COVID positive moms into the cord blood or the cord tissue. If anyone's interested, I'm happy to share that article with them. But yes, from the perspective of doing private banking, there is still the option to do. NYU itself does not have, a public or a private bank. You would still be working with like CVR, CBR or via Cords, and like you can speak with them or we can have you put in contact with them, but it seems that there is an opportunity to do it.
Great, and we have about 10 more questions left, so I do want to get to them before we have to end. What do most couples forget or overlook once the mom goes into labor?
I'm sorry, can you repeat that, Golzar?
I text messaged her, that's why she wasn't paying attention. What do most couples forget or overlook once the mom goes into labor?
I don't feel like anything. I feel like in this time of the pandemic, like everyone is very, very well prepared. So
over prepared.
Okay, this is good, but no, I don't feel like there's anything.
There is one thing we do want to remember, we've mentioned on the previous webinars, you don't want to come with suitcases full of stuff because you won't be able to leave and come back. Perry, do we have the essentials for delivery slide? Perry's going to put that up if she has it. So, you don't want to bring too much stuff because there is a lot of stuff there. In the previous webinar, we talked in depth about it. So you can always go back to that webinar. Oh, here it is. It's on your screen. Next question is, do we have to pre-register for the hospital? On delivery day, do we call the main Downtown Women line? What do we do to coordinate with Downtown Women's assigned delivery doctor that day?
Yeah. So we actually pre-register for our patients in the beginning of the pregnancy, so you don't have to worry about that. If you're going into labor, if it's between the hours of 9 and 5, you'll call the main office number, and then we'll get you over to the nursing line. And there's a doctor that partners with the nurse to talk about if we think patients are ready to head in. If it's after 5 or on weekends, we have 2 answering service phone numbers, a live team of people that will pick up. And then page the doctor on call. So in either situation, whether you're speaking with the office team or the after hours team, we will call NYU to let them know that you're coming. And in general, we encourage families to labor at home as long as possible, getting the contraction pattern down to every 3 to 5 minutes for at least an hour. If women are having their second or third baby, and labor progresses more quickly, also depending on where they come from, we may actually have them leave a little bit sooner than that. So maybe when the contractions are every 5 to 10, especially if they have a history of faster labor.
Great. So that answers my next question. Harry, can you put up the slide on contractions? COVID and postpartum.
Mm-hmm.
What is the discharge process like? What supplies will the hospital provide?
So again, we're practicing social distancing on the mother-baby floor. So women, if they have an uncomplicated vaginal delivery, encouraging going home on day 1, uncomplicated C-section on day 2. Again, these are encouraged. If there's something with moms or babies and we need a little bit more time, that's fine. I checked with the nurse managers just because I don't know, my patient told me that there was a posting somewhere about postpartum supplies and diapers and things to help with breastfeeding. We are fully stocked at NYU. That's not an issue. And then the nurses still kind of give, I always call them goodie bags. They give a little bit of like maternity pads, diapers, supplies to kind of get you through your first few days at home.
Great. Are babies being given face shields since they can't wear masks?
They are not. They are not. I think the biggest is having, parents and caregivers and spouses wearing them, right? Dr. Copenhaver, we're not masking infants.
I don't have any cute baby
Right.
shields right now.
They're kind of adorable though. Maybe next time we should post a picture of that in the middle of it. Can we leave the hospital on foot without a car? And does my husband need to bring the car seat with us when we arrive at the hospital, or will he be able to go get it and bring it back to pick him up?
Definitely, yes, should have a car seat. I would probably, in the setting of if the partner has to leave and then is only able to come back for pickup, I would bring it in together so it's in the room and the mom has it. So then she can just bring the baby down, like for pickup if he has to go. So we also had talked about like strollers, and we were saying, just to make sure I'm getting my pediatrics right, Dr. Copenhaver, the actual stroller that can break down into, or the car seat that can be placed in or locked into a stroller is the safest.
I don't think this has changed. Like babies are examined and cleared by a pediatrician to go home from that perspective of the discharge process. And I don't think it's changed, but a baby has to be secured in something to leave. You're not gonna be able to like walk out of your room just holding your baby, nor in a carrier. So usually it's in a car seat. If you're going to go home on foot, that's fine. But then that car seat, you could, I guess, schlep it home. But you can, if you have a stroller base, a lot of stroller bases have attachments. You can clip the car seat into the stroller base and then push it home.
What is your opinion on using Uber to get home from the hospital following delivery?
It's not my first option. If, I think if you have a friend or family member that could come, just because you don't know getting into an Uber car, just who's been in that car and how to stay safe. I mean, a lot of them now are masked. A lot of them have kind of this pseudo plexiglass or plastic. So I think it would be my last choice. Dr. Copenhaver brought up a great idea with the zip car, or kind of, yeah. Of renting that, and then that way it's just the three of you, just in terms of exposure. And the other good idea that if you do go into an Uber, just making sure that you see that's masked, that there's maybe some plastic kind of draping up, and then maybe even using kind of, most car seats come with a almost like a plastic wrap for baby, when sometimes it happens when it rains, that just to kind of keep the baby enclosed as well.
Yeah, and remember, if you have to order an Uber, that is the way that you can get home, because you don't have these other options, and the Uber driver shows up and they either look sick, or they're not wearing a mask, or there's nothing protective in the car, or you have any bad feeling at all, cancel the Uber, pay the $5 fee, and order another one. Just be really cautious if that's your only option. What does postpartum care look like in the age of televisits? Is there anything we should be looking out for in particular?
I think that, we're offering them for patients, just again to try to keep everyone home and healthy if they're feeling well and they feel like they're no complications. I think looking at the list that we give when we do discharge instructions, so if there's any, heavy bleeding or concerns about if moms are breastfeeding, or any increasing pain, all of these things normally say in-office visit. If none of those things are going on, baby's doing fine, mom's doing fine, feeding well, that's where the telehealth visit can help, social distance, but start discussion of, if patients have any other questions. A lot of women have questions about contraception at that point, and trying to decide what's best for each patient. And, if we think it's an IUD, then we can schedule you for an in-office IUD visit. Or if it's pills, we can talk about what type and send a prescription. But some women say, I'm having a discomfort here. I feel like I need to be looked at. We still can have an in-office postpartum visit. And just to remind patients, we are social distancing, so have a schedule in the office that there's 3 to 4 providers. The schedules are spaced, so it's not going to be hustling, big waiting room crowd. So getting women in, getting them seen, and then getting them back home. And we're going to continue that schedule for May and for June. And then we'll have to reassess what things are like in July.
And also remember, a really important part of postpartum care and that 6-week follow-up appointment is mental health. If for any reason you continue to feel sad or weepy beyond the baby blues, which is the first 2 to 3 weeks, if that is persistent and you are having strong negative feelings toward yourself or the baby, if you are crying a lot, if you feel inconsolable, overwhelmed, anxious, you don't even know how you're feeling, you're very detached, any of those things, you can either call the nurses line or you can call me or Perry at Downtown Women. And my email is on your screen right now. Please feel free to reach out at any time, and you and I can talk about what you need in terms of mental health support. So we are out of time, but do you guys mind staying on for 3 or 4 more minutes to go over a couple questions? I have a feeling the people who stuck around really want their questions answered. Okay, how is NYU dealing with the postpartum rooms and rooming when we're supposed to be practicing social distancing in terms of the roommates? Do you know that?
Yes. So when we're talking about that early discharge, I think that that's been very helpful, so that if women do not get assigned to a private room, and let's say they're going into a shared room, the fact that we're kind of keeping families going home, a lot of the times we've been able to keep that separate bed open, okay? And then I also think what is going to be reassuring about going back to universal testing is that now we know that people will be tested in COVID-19 negative if you do have to share space with them. So that I think that is going to help you if that happens. And that are COVID positive will be other places. So
great. At NYU, if a mother tests positive for COVID and is asymptomatic, can she decline the mother-baby separation?
So this is where I was saying it's going to be a case-by-case basis, but I would think if asymptomatic, COVID positive, I don't think at that, it's the people with symptoms that we're worried about are infectious, and I think that's where we would talk about separation. But just for like the patient I just spoke of who had symptoms a long time ago, and we swabbed her, no symptoms currently, infectious disease control, all felt like the baby should still room in, that there shouldn't be any separation.
I think it's important that the AAP recommendations that I said, they're recommendations, they're not hard and fast like rules. So yes, if you're like, I really want to room in with my baby, make your wishes known, and then likely that's going to happen, but there'll be discussion, like Dr. Whitehead said, there's going to be collaboration of teams and make sure that like everyone's the safest and that your wishes are followed as closely as possible.
Somebody asked about getting a one-pager for all the slides. If you want the slides, you can reach out to me or Perry and we can send them to you. We're happy to do that. Are the guidelines that Dr. Copenhaver shared with us regarding the best breastfeeding practices still necessary when the baby is older, 13 months?
No. If you're COVID positive, like if you are sick again, then yes. So like, if you're breastfeeding and you get sick, and it's COVID and you test positive for COVID, I would wash hands and wash your breast then. But beyond that newborn period and that 7 days, if you're sick, then they're saying 72 hours, no fever, or 7 days from symptom onset, or, they're saying 2 negative tests. I think it might be difficult to get 2 negative tests if you're asymptomatic. So maybe 14 days, then you can stop all of the additional washing and breast and nipple washing.
Great, thank you. What does universal testing mean? Is it just a temperature check or is it the swab?
Universal testing means that we are testing all patients and testing them with the swab. So whereas our screening, what before was just we would ask women and their partners as they come in, respiratory symptoms, doing temperature checks every 12 hours. So now when we say universal, it means all women coming into labor and delivery will have a COVID swab on admission.
Great. A friend told me that at NYC, taking an Uber with a baby does not require a car seat. I find it hard to believe, but could not find clear guidelines. Do you guys know that? This is not from the hospital because you do need the car seat for the hospital, but this is maybe to appointments to the pediatrician.
So I think, I think in cabs pre-Uber, you could put a kid in the back seat and like a cop wouldn't stop you, or like the taxi driver wouldn't say no. An infant should always be in a car seat, always. Backward facing in the back seat. I don't think any Uber driver or any taxi driver is gonna be comfortable with a small infant in the back seat. I think there's like a law that maybe they're referring to that like if you come in with like a toddler, you can like belt them in, and there's Uber Family that has actually car seats in the back seat, but they are not infant car seats. They are car seats for 2 and up because they are a 5-point harness forward facing. So you can't Uber Family and assume that they will have an infant appropriate car seat. So 2 and under, always in a car seat, always backward facing, and you're gonna have to provide your own car seat.
Great. If NYC goes back to work within the next month, what do you recommend for pregnant women and their partners who are non-essential workers and can work from home?
I would take the standpoint that, the pandemic will still be going on at this point, and if people have the opportunity to work from home and can still be productive in that way, I would suggest that for both the patient and the partner. Yes.
For potential helping caregivers who have been in isolation, is it better for people to get the Tdap booster from a doctor or stay in isolation? What is the timeline necessary around Tdap boosters for those who may be coming to help? As a mom and dad, we've been told 3 years, but grandparents are insisting it is 5.
Oh.
Do we know?
Grandparents, I say 5. That's what I typically have told people in prenatal care, because it's from the tetanus and pertussis thing. We don't have a lot of great data about the pertussis waning. So at least every 5 years, I'm not telling parents that they need to have grandparents get the DTaP to protect the baby every 3. Same with spouse, like our partner.
You do every 5. Yeah.
Every 5. I don't think Drew got another one for Brett, and it's been 4 years.
It's a good question, and I'm glad I'm here because I've been counseling parents 3.
I am all about vaccines. So like 3 is a great thing, but if that is a fighting point for a grandparent, then pick your battles. Try for a flu shot maybe. If it's been like 4.5, like I don't know, fight for that one.
Great. Last question, and then we're going to have to stop because I've kept these ladies online with me for 2 hours now. If COVID-19 seems to have very low mortality in babies, why is the policy to separate babies from COVID-positive mothers immediately postpartum? Are hospitals thinking about the consequences of infection versus the benefits of skin-to-skin contact? And how should new parents be thinking about this?
I think the hard part about it is that it's exactly what we're seeing every day, is that this virus is evolving. These protocols, because of that, the protocols are evolving. So, and this is why at this juncture, NYU has kind of created a flow sheet to talk about like symptoms versus positivity, and then what to do with moms and babies. I think, yes, it's traumatic for women, an extra stressor to be having babies during the pandemic. And then also thinking, you bring up about a point about separation of, you know, mom and infant, but I think where they're really going to recommend it is, I think, someone who's actively infectious. But I think there's a discussion with the team and talking about risk and benefits. And, you know, obviously patients have autonomy, but I don't think, I think the real risk, an example, when I was talking about the other two patients that had no symptoms and babies still stayed with the mom, I think it's going to have to be based off of symptoms. So I don't always think a positive test automatically means separation.
I think from the pediatric standpoint and the AAP, and I'm not a member of the AAP, and I'm obviously, well, I mean, I'm a member of the AAP, but I didn't make these guidelines. So we have so little numbers right now that even though the babies that have been born to COVID positive mothers, that very few of them have been infected, a lot of them, I think in the United States at least, have been kind of like socially distanced from their mom a little bit. And the babies that have contracted COVID-19 have done well. We do know that the kids under 1 are more likely to have more severe illness, even though it doesn't seem to be as severe as the adults. And with babies, we're always going to err from a pediatric standpoint on very, very, very cautious. And that doesn't mean that that is like the right thing in that one moment. Like Dr. Whitehead said, it may be case by case, but your job as a mom, is to advocate for yourself. And our job as doctors is to think worst case scenario, safety, protecting that baby 5 steps ahead in lots of different directions. So the AAPs guidelines are very conservative from that standpoint about recommending to temporarily separate. That's not necessarily every other country recommendation, and will maybe and likely change and evolve as we get more and more information. I think right now that we're just being very conservative to protect that baby from anything more serious happening.
Thank you so much. Thank you, Dr. Whitehead, and thank you, Dr. Copenhaver, for joining me today. We really appreciate it. Everybody, please fill out, everybody who's left, please fill out the feedback form, and we will have another webinar soon. Thank you so much, ladies.
Thank you.
Outside, everyone. It's beautiful out there, I hear. Bye.